Well, my name is Kevin James. I'm an orthopedic surgeon, and we're here at Cleveland Regional Medical Center. Today, we're going to talk about ACL reconstructions. And ACL reconstructions have been around for a long time, but today we're going to talk about a unique way of doing a reconstruction. It's an all-inside technique, and very few people have actually been trained in this technique. First of all, let's talk a little bit about what an ACL is. ACL stands for anterior cruciate ligament of the knee. So inside the knee, we have a large ligament that sits right there where my finger is. And that is called the ACL, or anterior cruciate ligament. The reason it's called cruciate is because there are two of them. There's a second one called a posterior cruciate ligament, and that is in the back of the knee. So if you were to cut this knee down the center like this and look at these two ligaments, they actually cross. They cross in the middle of the knee. Hence, they're called cruciate or crossing ligaments. So the anterior cruciate ligament keeps the knee from coming forward like this when we pull on it, and the posterior cruciate ligament keeps the knee from going backwards. The anterior cruciate ligament is one of the most commonly injured ligaments in the knee. You may have heard of athletes, football players, tearing their ACL, and they end up having to have the ACL reconstructed. So let's back up now and go to why do we actually fix these. We fix them primarily for stabilization of the knee. This type of injury is primarily a decelerating twisting injury. So a basketball player comes down from a rebound, a volleyball player comes down from spiking the ball. They load their knee and they're decelerating, and a little bit of twisting and their ACL blows. We're finding that women are a little more prone to it than men. Not sure exactly why. There are some theories to that, but we're finding that a lot of the women in sports now are tearing their ACLs, and so we're doing a lot of reconstructions for women. Like I say, there are lots of techniques for reconstructing ACLs. I've been doing ACL reconstruction for well over 20 years. When I started, we opened the knee, made a big long incision down the front part of the knee, opened the knee up, drilled tunnels, put ligaments in there, put them in a cast for 6 weeks, and then took them out and they were stiff. Then we finally started doing arthroscopic reconstructions where we made poke holes in the knee. And there are other techniques, but the one that seemed to really put ACL reconstructions in the forefront was the bone patella tendon bone. And what that is you make an incision down the front, and you actually take the middle third of this patella. You don't cut all the way through it, but you cut about a third of the way through it. You take the middle part of the tendon here, and you take part of the bone here. So you actually lift that out of the knee. Then, from the outside of the knee in, you drill a tunnel starting here, and that tunnel comes up in the middle where the ACL attaches. Then you drill another tunnel way up in this part, or the femur. And then you simply slide that bone patella tendon bone in the tunnel through the knee and up into the other tunnel, and hence you recreate another ligament in there. And you stabilize it with screws. Okay? So that was the older technique, still a very good technique. A lot of surgeons still do it. We've done some advances. We do some soft tissue now. You can take hamstrings, which are tendons that we can harvest, and we can wrap those around different devices and put them inside of the knee. So basically what you're trying to do is find another structure to put inside the knee. Bone, patella tendon bone, some of the earlier ones. Now we do soft tissue. We take hamstrings and put them in. We also take specimens from cadavers, people who passed away, and we can take the bone, patella tendon bone, we can take their hamstrings, and I use a newer one or a different type of graft, and it's an Achilles tendon graft. So I have part of bone, and then I have a soft ligament, very thick. So now you've got a little bit about what the ACL is, you know a little bit about some of the previous techniques. So what's different about this technique that I do? All of these other techniques are from the outside in. This technique is all done inside of the knee. There are no incisions on the outside of the knee. I have 4 poke holes at most, just big enough to get a screw in. So what are the advantages of this? The number one advantage, the pain is significantly less. I have people that I've done these on, I send them home right away, which most surgeons do. But I have patients that have taken 4, 5, 6 pain pills, and that's it. The second is the rehab is incredibly easy because they have no pain. Their rehab is virtually effortless, so they rehab very quickly. The third advantage that I see, and you actually have to see this or it has to be diagrammed. The older techniques, when you drill the holes in the bone, when the ligament is stuffed down in the bone, the screw is put from the outside in. And so the fixation of the ligament is down in the tunnel. They try to get it as close to the surface. As you see in the knee, the ACL is actually attached right at the surface of the tibia. But when you drill the holes here and you stuff the tendon down in there, the screw goes in here, so it's close to the surface, but it's not at the surface. When you do an all-inside technique, the screw is right at the articular surface. It's right where anatomically the ACL attaches. So I personally think that it's a better fixation. And the same way with the femur, there's virtually no difference in how the femur is fixed. But I think that fixing the ACL at the tibial surface, for me personally, I think is a tremendous advantage. And I use the Achilles tendon because it's a very, very thick graft. People that use the hamstrings, I've done lots of hamstrings, and I just feel that this is a much stronger graft. And taking it from a cadaver, I don't harvest anything from the patient, and I have not seen any significant difference between using a cadaver graft or the patient's own. And I actually think that taking less from the patient and putting something externally actually helps.
An Achilles tendon is much wider than what goes through that hole. You have to actually excise some of it, or
well, we size the graft to, we size the tunnels to the graft. So I take the tunnels and I might make a 10-millimeter diameter tunnel. So then my graft, I make sure my graft kind of fits through those tunnels.
Gotcha.
So we will trim things to make it fit. Most of the time I use a 10-millimeter tunnel, so I take the graft and make it a 10-millimeter graft so it fits in there. And then the screws fill up that tunnel, so we get a nice snug fit. But the technique there is a learning curve. This is not something that I would not advocate just having the rep come in and you do it. I have actually been to a school to learn how to do this, and it's technically involved. I think perhaps some surgeons might not, but this is me. This is not any studies. I think that it's technical, and I don't think a lot of folks want to do the technical aspect of it. Statistically, is there a statistically significant difference between the stabilization? Probably not, and I haven't seen anything in the literature that says that the stabilization of this is any different than the others. But I do think the pain relief is significant.
Less pain, easier rehab. Is it still roughly the same amount of time for full recovery, though?
I actually think it's less time for full recovery.
So in other words, an athlete, this may end up being the choice for an athlete in the future, right?
Let me qualify that. I think it's less recovery time for pain and getting their motion back. I still will not let my contact athletes go back to full contact until 7 to 8 months, which is about the same time as the traditional ACL. So I don't see any difference in that. I just think that early on they get back to doing some of their normal activities quicker because their pain is much less. So if you do this on an executive, they're going back to work within a week to 2 weeks. If you do it on a construction worker, I think a construction worker can go back a little earlier. An athlete, a volleyball player, a baseball player, a football player, they're probably still going to be 7 to 8 months.